since we are saying lifestyle, obesity, let's just highlight obesity kidogo. Do you guys believe that obesity should be talked about and insight should be given? Or do you believe that everyone has a right to their own body and you should not body shame?
I think maybe as an individual, I'll come. Okay, I don't know if this will be. Hello everyone, welcome to Laughing Lab Coach. Dr. Muhyiddin here.
Dr. Aziz here.
And this is your favorite doctor, Dr. Abdulhakim.
Mzee anatesa watu Instagram. Okay. So watu ongelea kuhusu kisukari sana. And in general terms, what would you tell them this is?
Diabetes, eh? Okay. In the layman's language, people call it like sukari, or what do they they call it sukari or ma'an in Somali, right?
Yeah.
So in the definition, it's just lack of insulin in the body or deficiency. What? Yeah. Yes. Or sensitivity of insulin or resistance of insulin to the body. So probably, I don't know how you can.
So to put it in layman's language it's when the sugar is not going out of the
Blood
veins and arteries into the
tissues
or the body. And insulin is like a key. It takes the blood sugar from the blood to the body. So when insulin or the key to take it out of the blood is not there, that is when diabetes comes
Or the
about.
key is broken somehow.
Or
It's not entering into the lock.
Or if the key is not a master key.
Yeah. Okay.
So it doesn't take the sugars from the blood into the body. And that is when a person develops a state of diabetes. So those are the two types, basically type 1 and type 2.
Type 2.
Yeah. Are there like ways you would foresee it's coming? Things that you tell your patients, even the public who really want to know, like, what these are the watch signs.
Yes, so I think that is when we are talking about type 2. Type 1, since it is genetic, by the time the patient is noticing they have diabetes, they've already developed a complication. For example, they'll come with diabetic ketoacidosis, which is a complication of diabetes. And that is when they will know that they have diabetes, because it catches them very young, so they wouldn't be able to explain the signs and symptoms like an adult. But the one that you can at least know it is coming, it is the diabetes type 2, because it's a lifestyle disease, and since people are not unfatting, it can easily catch you. And the signs and symptoms are basically summarized by metabolic syndrome. The metabolic syndrome is hyperglycemia, any lipid abnormality in the body, hyperglycemia, hypertriglyceridemia, and hypercholesterolemia, with an increased waist circumference and sometimes even hypertension. So once you start, once you start getting fat, if your weight circumference increase, if your BMI increases, that is when at least you can be categorized as pre-diabetes, and you are highly likely to progress to become a diabetic person.
I think I think in children, it's not, and there are ways where you can actually start advising mothers, and because since they are the majority of the times are the ones who are doing the care. If you notice your baby is mostly thirsty, kila time anataka tu maji, kukunywa, that's one tell sign.
Or not gaining weight.
Or anakojoa sana. Like you trained your baby kuenda kwa choo kukojoa, usiku hako anajikojolea, and then overnight unaona ikitanda iko maji all the time. People who bedwet, I'm not saying everyone who bedwets is a criteria for diabetes, but those are the signs where you notice this guy was not doing it, or this baby was not doing it earlier, alafu sahi ameanza kukua hivi, and they're not gaining the weight, they're always lethargic, ametulia, that he's not active like the other kids.
Mm.
So I think that's one thing to take note. And
That's true.
for adults, it's a bit different. But another question, there's something, this is very interesting. You notice that type 1 is not exclusive to children alone.
Yes, true.
True.
So type 1 can also happen in adults at an advanced age, and it is what's I think known as MODY, or maturity onset diabetes of the young. So it's diabetes of the young, which has come in a mature person. That's why it's called maturity onset diabetes of the young. So this is, I think it's also an autoimmune disorder that has happened and has damaged the pancreas, which is responsible for the insulin production. So I think especially that the trend has been since COVID started. Most of the COVID patients, or about I think 50% of them, are found to have diabetes by the end of their COVID illness. So you find someone has gotten COVID, and then after getting into maybe inpatient or ICU, then again is found to have diabetes. Someone with even no family history of diabetes. So that shows that the same autoimmune process that was happening the same immune that was provoked by the COVID vaccine will start attacking the pancreas and causing now the same symptoms or signs as the diabetes type 1.
Yeah.
To add on to that, I don't know that we talked about MODY. Slight difference is that in MODY, we say that maturity onset diabetes of the young. Once it's diagnosed, you find out that the pancreatic beta cells are still intact in MODY compared to type 1. Usually that's the only difference. That's 3 to 5 years, up to 10 years sometimes, you see that the beta cells are still intact. They are able to produce insulin. So the body is insensitive, the cells of the body are insensitive. Unlike in type 1, right, is the exact opposite. But everything you mentioned is right, where the onset, the symptoms, how it comes about, the age, less than 30 years of age, okay. But for MODY, if you take someone to the lab and you do this test, you see that possibly the beta cells are still able to produce the insulin, according to this model.
There's a journal I was reading where it's basically, I think, a woman. She was in her 60s. For over 30 years, this woman was on oral agents. Anaenda anatumia hizo dawa, no difference. Blood sugars back then, watu walikuwa napima tu na mkojo, I think.
Oh, yeah.
But as long as you have glucose, it'll tell you still have blood sugar. But if it was the value thing came in the last, I think, 20 to 30 to 40 years. That's when the people got the estimate. So she goes to several doctors. Kila mtu anasema, let's try a new drug. All in the event, this person just needed insulin. So jamaa mmoja akasema, umemeza dawa ngapi? Amemtolea box kubwa of pills, just showcasing everything that she's been through. And you notice that the main reason I'm bringing this point is the age limit part of it is not purely a thing you can assume and say because the numbers are here. We say this is type 1, the numbers are here, we say this is type 2. And sometimes it's majority of it, so it's purely speculation and hypothesis that it's immunity, autoimmunity, it's viral infections, it is genetics, it is interactions with the environment, vitu kama hizo that predispose you to it. Yeah, but sometimes you notice there is a select few people who are ages of 30 and above who will still get the same thing. Same too, because of that assumption, they get misdiagnosed for quite some time.
That's type 2.
Yeah, as type 2, yeah, and get treated on orals, which they don't need.
You don't need.
And
the other type of diabetes, probably, before we forget, is diabetic in pregnancy, the gestational diabetes. It develops like after 20 weeks of pregnancy. So we need to watch also that one. We need to be very careful with them. And when we are doing ENC profile, we just do just random blood sugar to check out. Yeah. Have you encountered any gestational diabetes patients?
I've dealt with quite a few. Much as I do not like that department, well, I see you Kwanini, but I don't like that department.
Are you saying you don't like women?
Actually, I don't put words in my mouth. Unataka nikae bed so niko straight.
You always refer to gynecologist.
But still, and I think pathogenesis, okay, clear symptomatology, ile complaints wanakujanga nayo, it's always the same. I think it's the hormonal side of it with relation to the pregnancy that puts them at a higher risk of developing the any.
Yeah.
The good thing about it, you'd say, is there's a chance it will clear out post delivery. I think 12 weeks.
Yeah,
12 weeks post delivery. And
and
then
proper follow-up.
and proper follow-up.
Probably.
Some of them it doesn't.
Yeah.
And it sticks.
So, yeah.
So, and
Especially those who have the characteristics of type 2. If
Yes.
let's say a woman was obese, had high BMI, that's
during
either
a pregnancy,
overweight or obesity during pregnancy, was not diabetic before but has gotten the gestational diabetes, it is hard for her to be non-diabetic after the pregnancy. Those are the type that usually go on to become permanently diabetic.
do you think there are certain things as a Kenyan society we tend to do that predisposes us to developing both the type 1, type 2?
Okay. I can argue a case for the type 2 because we say it's a lifestyle disease. Us as Kenyans, it depends. I believe it also depends on the social, what can I say, social class. So if you are from a low, I don't know, the books usually say one of the risk factors is a low, but I believe the low socioeconomic status don't take junk food as much as the higher socioeconomic status.
Weirdly, in European countries, it's very different.
It's very
It's
different.
the lower class
the
that
low-
usually take junk food.
Yeah. Uh-huh.
Okay, so in Kenya, I think the upper class of people think junk food is something.
Do we make it?
But it easy may change also.
Wait, let me ask you guys, how many times have you guys gone out on dates and given the other person junk foods?
Sisi tunakula salad.
So kama unapenda mtu girls, if a man takes you out to eat junk food, he doesn't like it.
Inategemea.
It's fattening in the bull.
Inategemea on one thing.
That's ironic.
One of the risk factors.
You might find cases where mother comes, she's obese, maybe she's not diagnosed with diabetes. She delivers first baby or first kid 4 kgs, the next one 4.2 kgs, and she's not found out to be diabetic. So how do you address such cases? Because diabetic mothers, gestational diabetes mostly, that microsome is related to that, and other of course other incidents. So we can also discuss that.
Yeah, you need to be
Yeah.
simpler.
Microsomia, a big baby. Maybe that is
How big
More
is the
than
baby?
more than
is it, I don't know, 3 point
4.5?
4 to 4.5.
yeah, 4.5.
And with regards to, I think not necessarily all obese mothers will develop the diabetes, but they are at higher risk. And you notice the macrosomia side of it, the babies themselves are at risk in a way. Not all of them will develop diabetes.
Okay, if I can also argue a case,
Mm.
and in pregnancy, usually there's a state of insulin resistance because of the hormones that are produced during pregnancy. Now, insulin resistance, what does it mean? It means that the sugar is more in the blood. And this is the same blood that is going through the placenta to the baby to nourish the baby, or not so? So the same increase in sugar that is in the blood will be the same increase in sugar that will be in the baby's blood. And this sugar in excess will cause overgrowth of the baby. So even just the state of pregnancy itself can predispose someone to have a big baby. but it varies according to how severe is the insulin insensitivity. Is it towards gestational diabetes or is it towards the normal side?
And yeah, on that point, I think there's that where it's hyperglycemia before the mother delivers. Then once they deliver, see that there's hypoglycemia, risk of hypoglycemia. So the dependency, the baby's dependency on the mother's sugar.
Yeah. So they go into hypo.
Yeah, so they don't hypo.
It's just that someone amelambishwa asali then
Yeah.
asali imekatishwa.
I raised that point because in Uganda, we've had so many
Sauti.
incidents where so many babies, and the mothers they're not diabetic, they don't have that. That's why it was a concern for me.
You used to take them to NICU, eh? We have a big baby here. Transfer to the NICU.
What's the biggest you've delivered?
The biggest baby I've delivered, I think it was 4.7. Yes.
5.
I think I've done 5.
Yeah, 5.
It was a hectic.
Very.
5 is no longer a baby. It's a young
Bro,
adult.
nilitoa mkono yake was like almost half this.
Was that CS?
Yes.
I don't.
CS, eh?
Ah.
Yeah. I also delivered a CS. Eh? It was very heavy. It was very heavy.
You don't even need to calculate the place.
It was heavy.
Unaanza na dozi ya dozi ya pediatrics. Sio neonate tena.
5
And
kg. It was
I
heavy.
think 5 kg is the baby that's usually used in the memes. You've seen that baby whereby they say when you are born and you realize that you're in Kenya, alafu mtoto wako hivi. I don't know if you can find that meme and put it on screen.
And so let's look at this from this perspective. You are 18, okay? You're 18 years old.
I wish.
You're 18 years old. You have symptoms of poor weight gain, exhausted all the time, thirsty, feeling like peeing all the time. So you're concerned and you go to the doctor. Majority of the times, daktari atakwambia hii inaweza kuwa sukari. So what do they do? What do doctors usually do?
If you ask your mom, she'll tell you jaila ko hai. So
You're not eating well, eh?
if you're peeing a lot, if you're not eating and you're 18 years old, haluda gawde mse wilkin jaila.
Happened. It's common.
What is the common approach?
But if you go to a doctor, I think if the diabetes symptoms are usually clear, if you drink a lot of water more than the usual, if you pee more than the usual, if you start eating or you have excessive hunger more than the usual, and if you lose weight. So if all those things are combined and you present them to a doctor, any qualified doctor will understand that the first thing they have to look for is diabetes. And one of the first tests that's done is a random blood sugar. So there are guidelines that are there to diagnose diabetes. One of them, if the patient has signs and symptoms and at any point a random blood sugar is taken and is found to be more than 11.1
Millimole, yeah.
Yeah.
Random.
but not just 11.1 with the symptoms.
With the
That's one of
symptoms.
the
Yes.
one of the criteria to diagnose. And the second criteria is what we call HbA1c. So the HbA1c, it's just based on half-lives of RBCs. So the usual life of the red blood cells in the air is 120 days. 120 days, that's roughly 4 months. But usually they take the lower end of 3 months. So since these red blood cells have been in your system for more than 3 months, they can tell the story that was happening for about 3 months.
For the past 3
Yeah.
months.
So what happens is the red blood cell is what we call biconcave in shape. I think you can put it on screen. So the biconcave shape is there to help the red blood cell to maneuver through tight junctions. But now, since this red blood cell has been bathing in sugar all along, what happens is sugar enters the red blood cell, it becomes hardened and it becomes round. So once you're taking the HbA1c test, that's what you're looking for. The glycosylation that has happened, as imekauka. So the normal limit Yeah, it's usually 6.5.
Yeah.
Anything above it is will tell you that in the past 3 months, this person's blood has been having a lot of
Sugars.
Yeah. Then I think there's a third criteria. Which I
The
forgot.
OGTT
Yes.
For
yes.
the gestational diabetic, right?
Mm.
it can apply for everyone.
The HB they won't see for diabetic and non-diabetic. I think the ranges are a bit different, right?
Anything
Yes.
below
6.5
6.
and then usually 7.
7. So but now when the person is coming, you don't know if they're diabetic. Yeah. So that's what the 6.5 is there for. If it's above 6.5, this person is diabetes. Now, according to where the person lies, if they're above 6.5, from 6.5 to 7.5, 7.5 to 8.5, and anything above 8.5.
Then-
Now, according to those groups, that's how you are given medication. If 6.5 to 7.5, one oral hypoglycemic, or one tablet to lower the sugar. In the second group, 2 tablets. In the third group, you do triple therapy. It's triple therapy for diabetes. So the HbA1c will also guide you on how many treatments, how many tablets in short, or how many different types of oral oral hypoglycemics that you have to use. Yeah.
And when it comes now, let's look at it from the type 1 perspective. And majority of the times you'd say 5-year-old kid amekuja na this, you just definitely think straightforward. But let's say this is 22-year-old person, of which I have seen like a good number, like over in the last 3 years, I think over 15 almost. And kijana mdogo anakuja, you see the symptoms, you're like, I'm conflicted. Is this type 1? Is this type 2? You already know, yes, this is diabetes that is there. You just want to specify which type it is. What would you do?
So nowadays it has become hard because these two types are overlapping a lot because of the lifestyle that people are having nowadays. See, before they used to say age less than 35 is type 1, more than 35 is type 2, but nowadays you get very obese kids at even I'm sure you've seen the Chinese kid
with the puffy face.
Trending on TikTok.
Yeah, so for that one, if you say it's type 2, no one will blame you. So they have an overlap. Yes.
Yeah.
Now the C-peptide one, it's you can't just do it for anyone who has come with high blood sugar, who is 20 or 30, and that person would benefit from it if he had stayed with that illness for 5 years. Pushing for the C-peptide test is for a person who's had a condition in the last 1 month is basically wasting their money.
Yeah.
Majority of the times you'd want to look at other autoantibodies. No, if this is from an autoimmune perspective rather than just taking the C-peptide, which would tell you the insulin levels. And then I think
but it's also a very important test.
it is a very important
to
test.
differentiate between the two. So in short, what the C-peptide means is before insulin is released as its active form, it has to be detached. The C-peptide become a key. So unless the C-peptide is detached from the insulin, it can't be active. So if this person has been having insulin deficiency, the C-peptide levels will be low.
Yeah.
If this person has been having insulin, but the insulin is not effective, that's insulin insensitivity, the C-peptides will be there. In the normal or even above normal ranges. Yeah. So that's one way to classify. But the other way is what the doctor was also saying. The best way, in short, is to check for those antibodies.
Antibodies, yeah.
To differentiate between.
Sensitive one inaitwa anti-GAD. It is the one which is supposed to tell you, yes, this is type 1 you're dealing with. The C-peptide one will just give you
where the insulin is
basically tell you your insulin levels. And talking about what is the impact of this disease? We've looked at it from a diagnostic perspective.
We have not mentioned other tests that we need to do.
Yes. Yeah. Thank you.
Like maybe the urinalysis to just check out whether there's glucose.
They come with.
Or
it is very important
like
to rule out when you're first diagnosing a diabetes.
Yeah, and other wholesome tests, like probably we need to check their kidney function test also. We need to check their lipid
profiles.
The lipid profile or the cholesterol levels, right?
Yeah.
in a layman's language. Just wholesomely, we need to do also the liver function test
So basically, there's a whole lot
And
of
the heart.
tests.
and the heart. Very important.
Why do we do all those tests? If let's say someone asks, mbona nafanya hizi vitu zote na mimi niko na sukari peke yake? So if someone asks, why will I have to do all these tests na shida yangu ni sukari, so nipe tu dawa ya sukari?
Like I think we need to diabetic affects organs, maybe the kidneys. We have something called diabetic nephropathy, which is a complication of diabetes. It affects the kidneys. We need to check out. We don't know how long this person had these symptoms or had this diabetes. We need to check out whether it has already affected the kidneys or we are fine.
I think the best way to put it would be, and once this blood sugar is persistently elevated, it will always find its way out.
Yeah.
It will always find its way out. The way it finds its way out is by going into places where it's not supposed to be. It will first showcase in your urine. It's not supposed to showcase in your urine, so you anticipate kidney problems to come in. It will go and affect your nerves because it's depositing itself on the nerves, so you start getting numb. It starts depositing itself slowly in the heart vessels, accumulating together with other tissues. You slowly start feeling chest pain, angina, pole pole, heart attack inakuja. Kidogo kidogo, some of them are so silent. The worst thing about it is these things are silent and you don't get the symptoms until it
The
is
damage has occurred.
last minute.
Yeah.
Until it is last minute. Not forgetting that it affects the eyes, the brain for stroke.
Yeah.
Your feet huko chini, you don't feel nerves. Your nerves are basically non-functional
Yeah.
or sub-functional. Yeah. And hauwezi sikia kama unachomeka and you get a wound. You get a wound, your blood is not able to, like there's poor perfusion to that area. Like damu haifiki kwa hiyo kidonda vizuri. Any place, a good wound is one which bleeds. If you see a wound which does not bleed, that is not a good wound. So
What if someone is heartbroken and you're telling them the wound has to bleed? Anyways, it doesn't apply in that scenario, but
toxic masculinity kauka kaa ni mwanaume umia. It's don't take that seriously. And that is the worst side of it.
Unabidi uzoe.
But then-
how about the situation now with case of having potential, because we talked about the organs failing because of the high blood sugars. Can we think about the fact that we have deficiency in insulin? So, for example, if someone has something like high potassium levels in the body, and insulin is supposed to remove potassium from the cellular back into the tissues, so someone can develop things like arrhythmias and heart failures and inflammation.
that's one of
That's
the
what the guy was
complications. But
talking about.
it also comes. It doesn't come because the insulin is deficient. I believe it comes because there's a kidney damage. Potassium, even if the insulin
So that's the original, the reason why we have high potassium levels.
Yes. Yes, but if it's just to look at the insulin insensitivity, it doesn't come because of it, because as long as the kidney is functional, it will always find a balance to either keep
It has its
or
homeostatic ability.
homeostasis, or release the potassium. But when we reach to the state of complication of kidney damage, that is when the potassium problems come. Yeah. The one thing I wanted to highlight is when someone talks about heart attack, what comes into mind? It's like, as you just pain, not so. But the doc said in diabetes there's nerve damage. So basically your nerve becomes senseless. So the is not there. You just get in a heart attack without you knowing, and that's called silent MI.
Silent
And
MI.
it's very common in diabetes. You find someone has been diabetic for long and he just does routine ECG. He doesn't need it because he's not showing any symptoms, but he just does it. And when he does it, you see features of old.
Worst of all, you are treating gastritis in your local clinics.
And sometimes the MI radiates, comes, it's called atypical
Yeah,
signs.
yeah.
It usually comes as maybe epigastric pain
Yeah.
or shoulder
Tapika
pain.
kidogo.
Yeah, in diabetes, it's very hard to diagnose MI because
Actually,
of the nerve
in
issues.
my line of duty, I found out that there was this diabetic patient who was going to clinics. He was being treated for gastritis every time, hyperacidity, and
Anapewa omeprazole.
yeah,
Kumbe
he's
ako
given
na heart attack.
omeprazole, anaenda huko anadungwa, and then he comes and then he explains the typical symptoms of an MI. We did an ECG. The troponins were very high. One of the markers of the heart were very high. Actually, he had STEMI, a blocked. It's a blockage, right?
Arteries that are
Yeah.
supplying the heart.
The heart. We had to refer him very fast to cardiologist for intervention. So that's what the doctors were talking about. Silent MIs, very common in our community, in our Kenyan society.
So,
There's a certain study I was looking at. It was done in Benin, a city called Port Nova, I think. They were saying that you notice they did like a whole study involving, I think, 180 patients who are known diabetics. Of the 180, it was like a 10 to 50 to 20-year study. It was a long one. And they noticed that these diabetic people will end up becoming hypertensive
Yeah.
eventually. And then to make it worse is, out of that 180 people who are followed up, majority of them ended up having something called arterial lower limb blockages, where mishipa za damu za miguu, not all of them, but like 50%. So that's basically 90 people of the people who they were following ended up developing easy arterial block, easy mishipa basically hazipeleki damu miguu. So some of them ended up with bad wounds that needed surgery. Some of them ended up losing a limb. So how would you prevent that? Is there a way you could prevent that?
Okay. So preventing, majorly you're talking about the peripheral arterial
Yes,
disease.
we already know this person is diabetic, and you just want to avoid as much complications as possible,
So
while not trying to lower the blood sugar to critical levels.
So to prevent a complication, you have to know the cause. So once you treat the cause, you treat the eventual complications. The reason these arteries are not supplying the legs very well, it's because these arteries are becoming hardened. And as you said earlier, and whenever the sugar is high in blood, it always finds its ways to enter where it's not needed.
Yeah.
So one of those areas are the blood vessels. Now you can just imagine the arteries and veins are usually elastic tissues. But when the sugar enters in the arteries and veins, in the walls especially, they become hardened. And when it becomes hardened, it becomes a rigid structure which does not easily expand to accommodate for more blood to flow maybe to the legs, especially in circumstances where it is needed. So at resting stage, your legs are not working, so you need limited blood flow to the legs. But imagine you're walking or running or doing any activity with your legs, when you need this extra blood flow and your veins have to distend, or the arteries have to distend to allow for more blood to come, it doesn't happen because it's rigid, and that's when you get the signs and symptoms. So to prevent that, you have to prevent the arteries and veins from getting rigid, and to prevent that, you have to lower the sugars, and to lower the sugars, you have to diagnose this diabetes earlier. So I believe early diagnosis of diabetes and adequate control will eventually prevent getting to these complications.
And coming down to control, and there's a certain target that you ideally want your patient's random blood sugars to be at. How would you approach it?
Controlling the diabetic based on medications or the lifestyle. First, we divide it into two for us to reach the target, probably. Lifestyle, which is the main factor, which plays the main role, and compliance to medications that we gave them. And then we follow up and check out to see probably random blood sugar below 9 or 11, below 11 is adequate, is a controlled diabetes. Probably we can also target lifestyle of the patient, probably losing weight or controlling their diet, a well-balanced diet, probably that.
There in the diet, there's usually what you call, is it DASH diet?
Yeah,
Diet against, what is the full name?
such
Something hypertension and something diabetes. So ideally what's advocated for in the diet is if your plate is round, you divide it into two halves. One of the halves is fruits and vegetables. The other half is divided into two
Moja
quarters.
mbili, yeah.
Two quarters. One of the quarters ni carbohydrates. Carbohydrates ni anything iko na unga, chapati, ugali, rice, etc. And
That's the plate method.
the plate method. Then the remaining quarter, it should be proteins. Proteins, anything from an animal. Meat, milk, eggs, cheese, etc.
Okay.
But you know what you usually do, especially in our community.
Chukua sinia
Unachukua
bigi.
sinia imejaa mchele, then
Mchele.
nyama iko hapo katikati kama donut. So it's basically carbohydrate with a
small protein.
chef kama mimi na Dr. Elias tunasemaga garnish. Garnish of proteins hapo katikati. So that's what's contributing to the diabetes also.
So it's basically lifestyle and medication compliance.
If you look at it from a type 1, because I think type 1s are more interesting as patients to me as an individual. And
You find joy in the patient's illnesses.
I'm sorry, but yeah, it's a learning curve. We all have to do better.
Since you had so many type 1 patients.
I've seen a lot. I have seen a lot. That's the
They're
thing.
so common by the
And
Sasa lakini you know some other people wanasikia Dr. Mhedin likes type 1 anasema I identify as type 1.
don't.
that doctor likes type 1 diabetes.
Sasa, and you notice there are some components of management that you can't really put together in this other group. This other group needs a different kind of approach to it. And one of my best patients is type 1, and I've been seeing her like for a while now.
It's
It's a
getting
person-
controversial now.
Seeing her.
It's a,
See, I like type 1 patients. One of
don't.
my best patients.
It's a young baby.
I like seeing her.
How
It's a
old?
young baby. Unataka
You should have
kujilebo.
started with that, Sasa.
It's a young
You see,
baby.
if you'll have started,
Seeing her.
see,
Acha ujinga.
you see, it will have,
How old is she?
Ako 12, I think.
you see, if you'll have just
yeah.
started with, I have a 12-year-old patient, I think it makes whatever statements coming afterwards
Okay,
easier.
so this patient, and there is a lot in terms of, I think, diet. Not just her, but majority of type 1s. There's a lot in terms of diet that they can't do the plate method.
True.
They can't
So
really.
the plate method, sorry for cutting you off. The plate method specifically is for losing fat weight, let me say that, because the carbohydrates is what is converted to glucose, and the glucose is utilized by the body as energy, and the
Stored
rest
in
is stored
adipocytes, yeah.
as fat.
Fat.
So the plate method is minimizing the amount of carbohydrates you put in your body to be converted to fat. That's why it has more vegetables and fruits, less of carbohydrates and less of protein. But losing weight will not work for a type 1
type
patient
1,
because they're
They're
already
already,
losing weight. So for them, I believe their diet is categorized into foods with a high glycemic index and foods with a low glycemic index. That suits them better, I think.
Majority of them usually purely need like a nutritionist to be on board, to guide them on calorie counting, carb counting, so that they can know if I take this, my blood sugar will spike to this amount. So for me to be able to prevent that, this is the amount I need to take and stick to it. And if certain symptoms will come, they do get relatively the same complications. But the biggest fear of most doctors, and should be a bigger fear, is the risk of that blood sugar going low because of you on high insulin doses. Umepatiwa a small amount of food to eat. Unaona umenyimwa for no reason. So it's a
so
bit
at,
risky.
we as doctors know that what will kill your patient is low blood sugar. High blood sugar will never kill a patient.
Yeah.
It's just the low blood sugar.
The-
High blood sugar will kill you over a period of time.
There's a time I think we
Yeah.
did this diabetes as a live. I don't know kama unakumbuka.
Uh-huh.
I think there was a scenario where we said umepata mtu wa sukari, ako na sukari, ako unconscious, just lying somewhere, not fully unconscious, but semi-conscious. You can see.
No,
You remember?
I remember.
And
Then we said the first thing you do if you just find someone unconscious, just give them sugar. Even if they're diabetic, just give them sugar.
Yeah.
Treat the hypoglycemia first. I remember now.
And on the part of the lifestyle, could you please exhaust it more in terms of physical health and mental health after being told you have diabetes, the stigma that comes around it, and how you mold your lifestyle around that?
now I think we can start with
Mental health guru.
The physical health, eh?
It will have been better if we had a lady talk about mental health. We as men, we are
Ndio kazana,
endelea na maisha.
sukuma maisha. For the physical health, probably we can, based on their age at that time, there are people who cannot do a very strenuous exercises. Probably those ones we can tell them to walk or give them a walking of 45 minutes or above 3,500 to 5,000 steps a day or something like that. That might be enough for them. For those who are active before, they can continue their active exercise. If they were in gym, they continue with their gym. If they are playing.
For the exercise, what's usually recommended is medium to light exercises, at least 30 minutes a day, for 5 out of 7 days in a week. So you
150 minutes
yes. So
That's 150 minutes.
in a week. Yeah.
in a week. So that's 30 minutes for 5 times,
I s-
5
I-
days in out of the 7. So it's
Send
basically
the gym
And,
alafu wapigwe na instructor.
Actually,
So
I
the
have a
fi-
scenario on that. I have a scenario on that. There was this 54-year-old. I was told this story by my dad. 54-year-old.
are you sure it
Ali
was not
died.
him?
It is not him. Alidiagnoziwa diabetes. Daktari alimwambia uko na diabetes. And then daktari prescribed some medications and then told him to exercise. Mzee amenunua boots. He went to play football at that age as a form of exercise.
So I think
He broke his limb.
Nilikuwa tu ref. Singe moja takuwa ref.
He had a femur fracture. He sustained a femur fracture. So
There's
that
some-
strenuous exercise also is not good.
there's some things
Lala.
there's some things you can't do at that age, but
I think the exercise bit of it would favor people with a metabolic syndrome, ile
yes,
high BMI,
Overweight.
mwili ingine, yeah.
Those who
Mwili
need to
ingine.
have
I'm not
fats.
body shaming anyone. Kila mtu akwe comfortable na skin yake, but still the reason why we're saying it's not good is because of what risks are there. But in this type 1s, they usually suffer a risk of hypoglycemia if they're made to exercise or they play vigorously. So that's one thing people should understand. I just wanted to put it across.
So Doc, let's since we are saying lifestyle, obesity, let's just highlight obesity kidogo. Do you guys believe that obesity should be talked about and insight should be given, or do you believe that everyone has a right to their own body and you should not body shame?
I think maybe as an individual, I'll come. Okay, I don't know if this will be controversial.
You as an individual and as a doctor.
Okay, me as an individual and as a doctor as well, because I'm combining the two. And by the time you figure out that your body mass index has traverse through, I think 25, you're
more
going
than 25.
more than 25, you're overweight, you become pre-obese and then obese.
Mm.
And at that point, your head should start raising questions
But-
internally, self-realization.
But what if the society is telling you should be comfortable in your body, and even creating terminologies for even in modeling? Zamani
Fat
modeling
shaming.
people were like slim, nini, and then now they've started to say big body women models. You see,
Plus size, huh?
BBWs, plus size models. You see, so what if the society is celebrating you, and and everyone is just telling you to be comfortable in your own with your own weight class, but should we be doing that, or should we be helping these people get insight and fatten?
I think it's, if you want to, I'll put it if I'll put it simple. If you want to make money for the big pharma, go ahead with it. Gain your weight, it's fine. And not everyone will come suffer the consequences of it, but studies show there's a risk somewhere down the line inaweza kuja, and it's everyone's choice anyway. If you choose to go with what the masses believe in, that's on you.
We say also prevention is better than cure. We know the risks that obesity comes with. I think as a doctor, your role is to always advise patients on the risk that they can get with obesity or
Just
something.
make
like
it
that.
a routine. If a patient comes,
Yeah, patient
we do
education.
the height, weight, BMI, waist circumference.
Yeah, I think
Something like that.
we need to advocate more on of like patient education.
But you know, the people who usually do it best are nutritionists. I feel like nutritionists
Yes,
Pay
this
more
country,
attention
yes,
to-
in this country are not even are
Yes.
not celebrated. Even they're not even sometimes present in most of our hospitals.
Now,
But those are the guys who usually pick it up first, know what to tell the patient, even better than the doctors.
I think also in our practice, I think we are all doctors. I've read also the KMPDC instructions. When you diagnose a patient and they're leaving your office, it's like you have not treated that patient if you have not done a patient education. Even if kama hata wako na homa, you get me? The prevention and the risk factors and all that thing, the follow-up. So I think we need to make a habit of doing patient education to the patients on lifestyle also, especially in our society, where we celebrate the junky foods, the KFCs and all that thing.
Okay, another question for you guys: do you believe the government or the health system, if at all they have leadership, do you believe they should do more about it? For example,
I know where you're headed. Let's hold on that. And we've looked at it from the physical side.
yes,
Let's look at it from
Mental
this
health.
person's psyche. What is it like? Wewe sahi ukiambiwa
It's very
"Doa
hard.
kuko na sukari," how do you take it?
Of course,
It's depressing.
it's depressing because everyone knows diabetes is a chronic illness, and by definition, a chronic illness is never ending. You'll have it
It's like a
forever,
death
forever.
sentence.
Yeah. So you'll have it forever, meaning you'll be taking the medications forever. Meaning, in the back of your mind, you know, all these complications. Maybe this person has been seeing diabetic people's foot chopped off. You see, it really affects you psychologically, and there is a mental aspect that is attached to the diagnosis of diabetes. So before, I believe that if someone comes to your office, you've done the lab tests, diagnosed diabetes on your own, before you break the news to them, just cancel them. Diabetes is a disease which is common. Yeah,
At that point, their head has already gone. Okay,
no, you know what I usually do?
Uh.
What I usually do, I just tell them, you see, before I tell you the results, let me tell you both sides. I usually start with if you don't have it. I say if you don't.
Do you ask them questions or
No,
you-
I am explaining to them. I usually say, before we look at the results, let me just tell you a brief thing about diabetes. If you don't have it, these are the things that you should do to avoid it, or to predispose yourself to getting diabetes. But if you do have it, in case we check the results, if you do have it, just know it's not the end of the world. It's
Some
a common
patients don't
illness.
take reassurance,
I give reassurances. I do patient education there and then by the time I'm breaking the news, at least there's some degree of
stability.
of stability in the patient side.
Okay. You notice majority of these guys, they start questioning nimi nimerogwa, this and why me, those questions, what will I do
Mario
next?
Balotelli.
Yeah, always me. And what do I do next? And thinking about the cost implications of
Very
medication,
expensive. It's
of
very
medication, screening and follow up,
Mhm.
and management of those complications if they come.
Even it's even good for patients' adherence to the drugs. Just by you explaining everything, making this patient's mental status stable will help this patient to continue the lifelong medication as per your dosages. You see, sometimes you just give this patient medication, then after a few months anasema, by the way, mi nimepona. Ama Koransar, anaenda Koransar, anaambiwa diabetes imeenda. You see, anaenda Sheikh Rushe.
Jump in, sorry for disrupting. In Uganda, there was something they used to do. I've not seen it commonly here in Kenya. There's that community outreach we used to do when we were in Fort Portal. But in Kenya, mostly it's not seen. So, for example, in our last year, is it the final semester? Like 5 of us, we used to organize something like is it a webinar or what you call, where you go out, you first organize it, and then you go out to the community, and then you provide things like biscuits or some form of entertainment, and then you teach them.
We give people diabetes.
Yeah.
You're preaching water and drinking wine.
Actually, some of the common topics we discussed, one of them, the chronic illnesses, how to prevent and dealing and living with them as one. The others were, is it female genital mutilation, COVID was one of it. So I think that one is something that's lacking in our communities where we come, where there's no outreach. We only deal with these patients when they come to us in our facilities. I don't know if you've noticed that.
Yeah, I think this is one way of dealing with it. And we are not fully we've not yet accomplished anything. Yeah, but I think with this being there, it's a good start.
So make sure you like, comment, and subscribe.
Please. Okay, I don't know. This is threatening. I should stop.
And then the obesity. No. Obesity, I think that Dr. Kim's idea, kind of more addresses the American and the Western kind of society, because here, where we hail from, Somalis, we are also Somalis, where we hail from, if someone is obese, that person
it's very healthy, eh? No, according in our house,
it's healthy. That's what they'll tell you.
You're very healthy. Mashallah,
have you seen if someone lives with, for example, is obese, they don't even have that personal security among themselves. And like in the Western society, where you're told your body, your choice. I don't think that your body, your choice is around in Africa.
Nairobi is
when you get married,
is the London of East Africa, New
Maybe
York. So it is coming. It is coming. It's already started anyway. Okay,
in our community,
TikTok sahi mtu ndo anarukaruka naambia endelea.
In our community, have you ever asked yourself why the newlywed guys become more heavy in the first 3 months of their marriage? I think it's because I think it's
an answer, but it's because wanalambishwa sana.
Yeah,
they
that's
take
what
more
they say,
sugar,
actually.
they become
Our girls see pride, like the guy is good. The guy is
during
good
the first
another
3
thing.
months. Wachana na ile 3-course meal. I think wanapewa 10-course meal.
Yeah, of course.
Wanakula mara mingi. The woman wants to showcase maybe her cooking abilities.
Cooking talents, and that's
So
it.
in that 3 months, zile cuisines umekula. Hey,
And they see it pride by them being told like your guy is
by the
good.
time
It
They
never
see
stops though. Does it ever stop? I don't think it stops. Because
it does.
inategemea kenye utafanya.
The question that always arises in the communities, does lumbar sukari mingi, does it cause?
It's very important.
Yes.
I've gotten that a lot.
Yeah, so much, a lot. I think we can discuss later.
I think your body already has ability to regulate sugar. Whatever amount of it you consume, yes, it will have the ability, but it depends on how repetitively you do it. How repetitively you do it. If you do it repetitively, you're exhausting your beta cells. Zile zinatoa insulin. You exhaust them while doing other things that put it on more damage, kupiga fegi, kukunywa, and not being active, eating just junk. You're overexhausting it. Eventually, at some point, inafika a place where you no longer able. You have the reduced amount of it, and you also have it not being used where it's supposed to, because the places where it's supposed to go to, kwa hiyo kifunguo, it's blocked.
So I believe hiyo kulamba sukari, it's talking about the glycemic index. If you just do it once or twice, it's okay. But if it's not about kulamba sukari, if you're eating foods even that have a high glycemic index, what happens is, let's say today your insulin level is here. You've taken a high amount of sugar or foods that are high in the glycemic index. You have to now produce more insulin than what you're usually producing to cater for that excess sugar. Now you go from this baseline of here to here. Then now what happens is the next day you come, and since you've now raised your baseline, you're taking again foods that are again high in a glycemic index, or you're just taking more sugars. Now your baseline goes high and high and high. So what is producing this insulin? Remember, it's your pancreas. Now it reaches a point whereby you're overwhelming what the pancreas is producing, and now the pancreas starts getting damaged. Once you start damaging your pancreas, now you'll start developing the diabetes. So that's how, and eating foods that are high in the glycemic index, ama kulamba sukari mingi, that's how it contributes to you getting diabetes. It's not that utalamba sukari inaingia kwa damu and then unapata diabetes. Not so. It's about how you're increasing your insulin levels gradually, and how you're exhausting, not damaging the pancreas. Yeah.
And there's what else? Oh, there's one important thing, and there's
There is hope for a drug-free life for diabetes.
According to Americ's days.
I think before we come to the drug-free life, and this has a part a bit similar to it, which will help explain. I don't know if you've come across some brands which say meza hii 2 months hiyo kitu imeenda.
Yeah, ni
Yeah.
herbal
Yeah.
medicine ama ni dawa za kawaida?
No, like even some, okay, like majority of them just have multivitamins, myoinositols.
I've not seen any.
Those are just businesses.
Those are business.
Take this within a month, that will be eradicated.
Guys, one last question. Do you guys believe that diabetes is a multi-million-dollar business affair?
It's an illness. I don't believe it's a business. It's an illness. Of course, where there's an illness, someone has to profit from it. But just by profiting from it, just if you're still providing the medications to help these patients, I don't regard it as a business. According to
I think
me.
that's a tactic that's
Yeah.
used majorly by the competitors in the market.
The competitors, those who
want to advocate for medications which are not clinically proven to work.
exactly, yeah.
So they will say you are daily on metformin or daily on glucophage.
See,
Trying to
the person is already obese, has already all these risk factors, is diabetic. Do you believe the medications help? If you believe the medications help, then I don't think we should regard these enterprises as business models. If they're providing help to the patients, if they were not providing all the help, then we could say these are businesses making money off it.
In most cases, what happens is those medications, a person has been on lifelong medications, they eventually still die of complications that arise from this.
Even if you control your sugars well,
the chances are
No,
lower.
even
Death,
the
death,
the
death
chan-
is for everyone.
Inevitable.
It's inevitable.
No, even
But-
without the complications, as you said in the definition, it's a chronic illness. This person will have it for life, this condition. So which means they will have to be on these medications forever.
It depends.
That's me.
It depends.
Mhm.
And you notice, and let's say you have a patient, okay? Ako age group, let's say 50. She's come, you said this is newly diagnosed type 2. You now on follow up with her. Her HbA1c level was, let's say, 14. And now you say, I cannot just start you on pills alone. Let us do insulin together with this. You start exercising, you watch what you eat. And then you give her 3 months. She goes 3 months, comes back, the insulin levels, the HbA1c levels come back to 10. You say, okay, now I'm removing you from the insulin. I want to see how you'll do with these 2 drugs or 3 drugs. You continue for another 3 months. It comes down to 7. 7, you give her another 2 months while on one pill, and keeping in mind this random blood sugars are coming down as well, and the fasting blood sugars, they're also coming down, and she gets to a level where she's now pre-diabetic and she's purely on nutrition and lifestyle control. This is someone who you have removed majority of the risk of those glycated end products, where the arteries become stiffened, where there is damage to the nerves, where the risk of MI has gone low. And you've taken this person from a point where by the age of 57, 58, she would have had 1 or 2 complications. You've moved her from that using these pharmaceuticals to a point where she's just on her food. So there's a lot you have avoided at that time.
If now you thought of that at the beginning, no, I'm not giving my patients any diabetic medications because I don't want to promote these businesses. You wouldn't have helped that patient up to the point where she gets.
The elephant in the house is, can we reverse diabetes?
I think the diabetes is something that is itching so many people's brains, from doctors to biochemists to immunologists to lab technicians. There's a lot about it that has not yet been discovered, and there's a lot in terms of and I was asking one of my consultants, it was like people are doing research on assessing if it is related to vitamin D levels. If vitamin D levels have dropped, or yes, there's a high chance of diabetes. They come do the research, see there is no specific good correlation between the two. They say it is related to the B complexes. They say it's not related to the two. Okay, there is, yes, if you don't have the specific nutrients, but it is not the cure for it. When it comes to saying this, ni kama nakupea dawa malaria, shika hii siku 3 kwa sawa. It doesn't come across that way. So there's a lot of research being done globally.
But it's becoming very prominent as metabolic specialists, not just these what do you call just people, the common people that just usually talk about diabetes, but people with knowledge, the metabolic specialists are talking about reversing diabetes.
Endocrinologists.
Not endocrinologists. There's some metabolic specialists now.
Yeah, there's metabolic
What the
specialists.
specialists are talking about, they have reversed the diabetes in some patients by putting them on low carbohydrates and more animal-based food.
Animal-based, like?
More protein, less carbs. Some even talking about 0 carbohydrates.
How do you do it for type 1 now?
No, I'm not talking about type 1.
Okay.
That's for specifically for type 2.
Now, for type 2, as long as majority of it is related to the lifestyle.
I think we can explore further this idea of type 2 being a reversible disease.
Illness.
More so if it is due to insulin resistance.
That's true.
But there's something we are missing. You see, in type 2, it starts with insulin resistance, but it ends up to be insulin insensitivity, a lack of insulin.
Lack of insulin.
So then you again move into type 1 again. So we can't now say type 2 diabetes is reversible. We just deal it as patient based. If even I don't know the study, if it's a real study, it should have been published, and guidelines should have been put in the medical books, saying that if you do this at this stage of type 2 diabetes, we might reverse. So just by it being a study, I
From
think
your clinical experience, have you ever had any patient?
no, I've never had any patient.
I've had one.
Pre-diabetic or
No,
diabetic?
like full on diabetic.
Full-blown diabetic.
Full-blown diabetic. We started with insulin, moved slowly back for over 1 year, 6 months.
Yeah, but
Moved down slowly with up to a level where she's now on nutrition and
It
exercise.
should be clear that when the person is the sugar level is too high, we don't just stop the medications at all. We
Yeah.
should stop the medications as we try to lower
Is that how old was she, doc? I'm sorry, I ask like always the age, eh?
She is 65.
Or 65. Because sometimes we,
it is done in a 65-year-old.
Uh,
I think it can be done.
some of our girls nowadays are misusing steroids also.
Steroid induced, yeah.
Yeah, steroid induced.
You
Eh?
have to remove all the previous.
Yes,
Start from there.
yes.
You remove the previous, then you start them on medications as you tap around the medication.
Why do you think the steroid induced thing is too common now?
Beauty standards.
Beauty standards.
What
Another-
is wrong with the beauty standards? What do men
Another-
want?
But I think this thing is misinterpreted. Okay, let's say this lady is taking steroids to look for a fat.
Big bunda.
Yes.
Big batty girl.
Exactly.
Mturinga.
Wait.
Mturinga.
Let's say this lady is aggressively taking steroids to look for a fat ass. But if you look at the pattern of fat distribution in relation to steroid,
It is not the
it is the
desired one.
complete opposite. What is usually described is women have an apple-shaped fat distribution, meaning an apple. So meaning big down, thin up, slim up. But
Okay.
men have a pear-shaped pattern, whereby it's big chest and arms and nini, then slim down. And steroids give you the same pattern as the men, the pear-shaped pattern. So it usually gives you fat distribution on the face area, on on the nini, unakuwa
Neck.
kama ngombe, unakuwa na hump, neck area, moon faces. It even gives you abdominal distension and striae. Yeah, so it gives you inakupea fatness from waist up, not from waist down. So I think that's really misinterpreted also.
I think, and to add more on this
Unakaa
steroid-induced one,
unakaa Teletubby na hiyo sura.
the more on the steroid-induced one, people take lightly on skin lightening creams.
Yeah.
People take that lightly. You won't just have kaskas, that one. Hiyo kitu, it's too common.
Yeah, I always hear about that. What's
People who fail in chemistry.
Excuse me, they are really
What is it proposed?
Mtu ako na lab ndani ya
ni nini
nyumba.
iko nayo kwanza?
They go buy creams and medications which have steroids, mix them. Some of them are rich in mercury, rich in lead, wanazimix. Alafu mwenye ana mix amevaa nini. I've been looking for a video. Kuna beshte yangu nimemtuma enda nitafutie.
are they mixing or they are cooking?
Eh,
Anaitwa nani huyo jamaa? Anaitwa nani? Professor what?
anaitwa nani?
Breaking Bad.
Breaking Bad.
So wanacook, I think. They're chemists. now.
Was it Walter?
Walter O'Brien.
Walter White.
Walter White.
Walter White. Walter O'Brien is someone else.
Sasa
Eh,
so the person doing it amevaa gloves. Shaicheki zile gloves za kuzalisha mang'ombe.
eh. Amevaa game gloves and mix.
Ako busy, ako
He's
hapa ana
cooking,
mix,
eh?
alafu anaipiga sachet, anainini, alafu
Anai
tomorrow
brand.
in the market
And then
kuna jina yake.
Nowadays they even open the marketing. Inaitwa original pastas.
But do you think it's because of I think men have to play a part in it?
We have no role in that.
I think
Let me put it in this way. This is a lady who is not comfortable with her skin. Maybe that's the reason she's changing it. She maybe anakatiwa na mwanaume, and that man ends up leaving her for a woman who is more light skinned.
Light skin.
You see, or this lady gets rejected several times by men, but the same man is going for a light skinned girl. So this lady is like, let me be light skinned, maybe I'll get noticed. And it's that sense of insecurity. I believe it's that sense of insecurity that leads them to this causes. So do men still have a part to play or not?
Tell us how dark is your girl.
I think they do it. I think they do it more for ladies than they do for boys or men. In that
They do it for their own
For men, bro.
uplift of beauty studies.
with another lady.
But why
would they
is she
compete in the
competing with
first
the other
place?
lady?
No, they are not interested.
Of course.
They are not interested. You know that even ladies dress for other ladies, not for
But why are they competing?
just for ego and self.
No, why do they have to dress for another woman?
We need a woman's perspective on this. Where Nyamazeni. We need a woman's perspective on this.
They should come and tell us.
They should tell us.
Those who- but we have nothing to do with it.
Oh.
I wonder.
How did you
You
get
guys
your
you
diabetes
reject
to
us,
that point?
man.
And
Steroids.
there's a certain drug I wanted to highlight on it. I've been seeing it trending on TikTok. I think may come across Unimate. The Unimate.
The one that gives twins.
It's some herbals. They say they market it as a supplement that is meant to reduce your body weight. You get and control your diabetes eventually, and
Is it a
reduce your.
pill? Is it a pill or
It's some powder
Powder.
solution.
Oh, yeah,
you
yeah,
mix
yeah,
it.
yeah,
I'm
yeah,
sure
yeah.
you've seen
I've
it.
seen it.
And
You
So I believe those powders, what they do, they give you severe diarrhea.
Diarrhea.
and
Bad
vomiting,
ones.
forget even the side
what
effects.
they do is whatever someone is taking, it goes out through. So I think they added some laxative in those powders.
It's not even about that. I went deep and researched into it.
Did you
They
take
have-
it?
Natafuta unono ama ukonde where. And so
Kwanza mimi nikitumia
they had three things. They have chlorogenic acid, they have tritapine, the other one I've forgotten. So these three things, they come from naturally occurring foods. So moja inatoka from cocoa, ingine inatoka from I think apples and cashew nuts.
But why not take the cocoa, apple, and cashew nuts?
Exactly. So the main target of this drug was to look for people who do not have such nutrients being availed to them. People who are in office jobs just taking chai ya maziwa ama ya strungi na mkate asubuhi, lunch ugali, sukuma, jioni, who miss out ama they eat KFCs, pizza kwa ofisi, those people who have that kind of lifestyle. And I went ahead and asked, and one of my consultants ni nephrologist, nikamuuliza, there are so many things that are sold out in the market, there is this one which has this. Kasema, for those who have the money, go buy. For those who don't, kula hiyo kahawa yako.
Cashew nuts.
Kula cashew nuts
and the
yako.
apple.
Kula na apples zako. We see how it will go. But and now
Those things are usually there in the market to take advantage of insecurities that people have.
oh, the Nini is dead.
Like finish.
Oh, okay. So to finalize, yeah. This is a big topic, and majority, what can we as a society do? What can you as a healthcare professional do? What can the government do in order to reduce the amount of expenditure or alleviate how much of a burden it is to the society? Because the amount of money was about 230 million USD spent on just diabetes in Kenya, yeah.
That's too much.
Just in summary, what we can do as individuals is improve our lifestyle. So that means exercising, that means avoiding junk food, that means recognizing or being aware about signs and symptoms of diabetes, being aware of the risk factors that might predispose you to getting diabetes. That's us as individuals. Healthcare workers should be able to recognize the signs and symptoms of diabetes. They should be able to diagnose it effectively, because there's a lot of misdiagnosis of diabetes nowadays. You just someone comes into a clinic, you do a random blood sugar, it gives you readings of 14, and you haven't even asked if this person has taken juice or something before doing the test, and just you label this person diabetic.
I've seen it happen in trauma cases a lot.
Yes, because in trauma there's stress, and whenever
There's
there's
stress, yeah.
stress,
Cortisol hormone goes.
yeah, the random blood sugars are up. So healthcare workers have to know how to correctly diagnose diabetes and how to correctly administer the type and which type of the drugs to administer. In if you look at general, the government, what they can do, they can maybe include adverts of healthy living, of diabetes awareness, maybe provide programs, because I've seen they've started the afya is it healthcare mashinani programs that they are going up to the grassroots, so they can do awareness of diabetes up to the grassroots level. They can also maybe provide public spaces whereby people can come and do the exercises for free. They can
Regulation of junk food.
the regulation of junk food is a controversial thing.
That's a very
Yeah, it's a very
you'll
hard
be hurting
thing.
people's pockets. But it's a necessary thing. The earlier you start talking about it, the better.
Yeah, true.
Because
Because it's a pandemic.
Yeah.
it's a
The
silent
obesity.
one.
Yeah,
It's a silent one.
So health government should not celebrate junk food,
Taxes.
because you go to the national media televisions, KBC, Citizen, nini, you find them they have adverts, sijui nini, Coca-Cola, unapata mtu anakunywa Coca-Cola. But so governments can do that in general. So that's my summary.
What do you have to add?
As a doctor, we need to do also patient education to our patients, whether they have diabetes or not diabetic. We need to talk about them. We need to teach them about it, tell them about it, because when you check, 1 in every 3 patients have a risk of developing any chronic illness or something like that, specific, especially diabetes. So I think I'll add patient education on diabetes. The rest, the doctor has talked about it. For the government, we don't expect anything from them, of course. Let's be honest about it. We don't expect, because those guys have
Daktari amefinywa na taxes.
Disappointment.
it's a disappointment.
Shukra.
They've actually employed people who don't even understand community health workers. I don't know how a community health worker will going to diagnose a diabetes or will going to tell a patient about diabetes.
And I think the most important, there are a few things you have left behind. Number one, you've looked at it from an individual's perspective. You said it's all on you, but you're not alone. Majority of the work, you have to do it. If it's checking out your diet, it's on you. If it's doing clinic follow-ups, it's on you. If it's having a multidisciplinary team who is seeing you, stick on it. Don't lose that. And if it is the mental side of support in it, is where we need to create support groups. I've never come across support groups in Kenya.
The one, for example, Alcoholics
Anonymous. Now, things like this, people who are even having psychiatric illnesses, diabetics, they can have their own little small support groups that is recognized. Like the same way the people with disability have their own and they're recognized. Something like that for the diabetics, for the hypertensives.
Diabetics Anonymous.
Yeah. And that is one way the society can think about this. I think
even more people, if more people who have diabetes and already have insights can come onto social media and from their part educate people. I've seen one lady I forgot her name, but I've seen she usually talks about her condition, the challenges she usually faces. So I think other diabetics elsewhere can relate to her condition really well and
Yeah.
improve in patient insight.
And
That's true.
I think when it comes to the government, and when it comes to the government, the last bit, sorry, when it comes to the government, I think they need to have. Do you know that anti-TBs are ziko Kenya? Just before I say that point,
Haziko Kenya.
like it's done. Like there's no accessible anti-TBs.
So if someone has
Akona,
TB,
if you diagnose TB, say that person will be without drugs.
Why?
There are no
didn't know that one.
medications in Kenya. Anti-TB drugs are ziko.
Oh.
Yeah.
also if you diagnose TB, we refer to Uganda.
I don't know.
Ama
But there are no
Tanzania.
drugs.
So why? I didn't know that one.
Are donated.
So
Because sometimes you
the donations stopped, eh?
Is it stalking? No, what is it?
I don't know.
So in short,
Ama
don't
ama-
diagnose someone with TB.
ama
I've had some.
ama Zakayo ameanza
last
Zakayo
week,
ameanza kutax, eh?
last week niliona kijana mmoja akona Pott's disease anaitafuta. He went from Kenyatta to Mbagathi to Mama Lucy to private hospitals just looking for anti-TB drugs. So
So don't get HIV.
yeah.
Don't get HIV.
So I think I don't know if it's from the side of the government or what is going on, but we need to address it. Final bits. What do you have to say to the people watching?
Like, comment, and subscribe.
Yeah, like, comment, and subscribe. Eh?
Big
thank you.
ups. Thank you
Big
for
ups.
this.
Bye bye.